Hi, I'm Svati Shah. I'm a cardiologist at Duke. I run an adult cardiovascular genetics clinic, and my research is in the genetic epidemiology of heart disease.
I'm Tom Cappola from University of Pennsylvania, and I'm a heart failure specialist and who studies genomics of heart failure and heart failure therapeutics. And we're both from the Functional Genomics and Translational Biology Council. Svati is our chair. Hi, Svati. And I chair the program committee. We have just completed what we hope to be a tradition of having a precision medicine summit embedded within the AHA scientific sessions. And we're here to comment on the latest session, which was called Precision Medicine on the Front Lines. Lots of interesting science presented, wonderful panel discussion. And maybe we can begin by just highlighting some of the interesting points raised. You were just talking as we were walking over here about familial hypercholesterolemia and how in Norway there's been an enormous effort to genotype the population and assess risk at an early age. What particularly struck you about that as interesting?
Yeah, Tom, it's a great question. It was such an interesting study that they presented. They were looking at patients with familial hypercholesterolemia in the country of Norway. Norway has an amazing resource where they actually provide genetic testing free of charge to Norwegian citizens, and they have all this genotyping information on these individuals, and so they're able to diagnose patients with heterozygous familial hypercholesterolemia and implement therapies earlier in life, hopefully before the incidence of an event. This study was really looking at what is the incidence of coronary heart disease and myocardial infarction in patients who have heterozygous familial hypercholesterolemia in Norway. So I think the idea of having that kind of network and a partnership between public health and government to really provide important genomic information to patients and their families, where 1/3 of the patients in that study were the proband who had presumably high cholesterol, which led to the genetic testing. But in fact, 2/3 of the individuals were actually family members who underwent genetic testing because of cascade screening. And even though they have this remarkable network, they actually did find a significantly increased risk of having coronary heart disease and acute myocardial infarction in those individuals. And it really highlights the potential and the need for early intervention in these patients. And when we think about the potential to reduce heart disease, this is really a very important genetic disease that holds great implications for prevention. I was really excited about those findings. And Tom, I'd like to ask you, there were quite a few studies about pharmacogenomics, and I was wondering about your thoughts about the use of pharmacogenomics in guiding how we treat patients with medications.
It's a great question. So one of the interesting studies was a study in which, in the real world, the pharmacogenomics network, the IGNITE network, tested whether in the cardiac catheterization laboratory, information about genotypes that influence antiplatelet response would affect physician behavior, would be feasible to use, and would affect outcomes. And the answer to all of those questions was yes, it was feasible. The turnaround time for genetic testing was very quick. It did influence to a certain extent the physician's choice, and that did have an effect on outcome. So it's a really important proof of principle that pharmacogenomics in practice can have a meaningful impact. You know, we also talked about the barriers, right? So the costs associated with it, the idea that doing genetic testing, just like any other test, is at a different level than genetic testing of a family for disease risk. That's an important distinction. So many questions were raised by this study, which really get to the frontline question: how do we begin to bring genome science into practice? And this was a good example. One of the other intriguing studies that was presented was a very large-scale population study, a collaboration between China and Oxford, in which there was large-scale genotyping of nearly 500,000 people, and cardiovascular events were tracked. In a subset of those people, lipid panels were measured in detail. And then they asked the question, if you identify genetic variants that abolish the function of a gene in the lipid pathway, what happens? And the idea here is to use genetics findings to predict potential drug response. You know, should a company bother developing a drug to inhibit that particular pathway. And they could replicate the prediction that CET inhibition would not affect cardiovascular outcomes, even though it does affect lipid levels. So I thought that was a particularly interesting example. And it shows you that having these data can inform drug development. Not in its entirety, of course, because drugs are more complex than just a single loss of function variant. They hit multiple targets in general, so the trials are important. But I think that this kind of information can help guide the choice of which trials to do. So I thought that was a very interesting study.
Agreed. There was another study that was trying to get somewhat at pharmacogenomics, took an interesting tack at looking at side effects of medications. So patients who develop, we know there are patients who develop very severe muscle side effects from taking statins. But we also know there are patients who have side effects of muscle pain from these statins without a clear evidence of actually having muscle damage. And there was a really interesting study that looked at potential new genetic variants that would determine somebody's susceptibility to have these perhaps less severe but important to a patient side effects from medications. I was wondering about your thoughts about that study and what implications that would have for how we take care of patients and guide them about statin therapy.
It's a great question. The guidelines show the unequivocal benefit of statin therapy in a variety of settings. And we also know that aches and pains in clinical practice can be an important symptom of an underlying problem, or could be unrelated to the drug you're giving. So that's really a question. I wonder if someday, we are not there yet, but I wonder if someday you could consider a genetic panel to sort of guide you. You know, should you be on statins or should you go more toward PCSK9 inhibitors, for example? I think right now the data clearly say everybody should be on a statin who has an indication because they're cheap, they're effective. But over time, it's a good example. Can you make that choice? So it was a very interesting study.
I wonder how far along we are in precision medicine. I think all the studies, all 4 of the studies that we discussed at the Precision Medicine Summit really highlighted important findings that could lead us to taking care of patients. And I wonder what your thoughts are about how close we are to using this in practice. I think the IGNITE network shows that this is being done in a lot of different institutions and the potential implications of that genetic care. But at a broader level, how close are we to the promise of precision medicine?
I think we're early days in a journey. Depends on how you look at it. I mean, for clinical genetics, we've known about Mendelian disorders for a long time. One of the struggles that we have, we were just discussing this on the way over, is training cardiologists to really think about genetic disease and use genetic information. There are areas in which, as you know, as the head of a genetics clinic, these are actionable conditions, and there is a shortage of cardiovascular practitioners who have the skills to really apply that in practice. So I think there's a training path. So the thing that the most important take-home message for me is that I need to go back home, encourage my fellows to pursue a path in cardiovascular genetics and precision medicine, because there are going to be jobs, there's going to be a need, and as members of academic centers, I think we're beholden to make sure that happens.
I think that's an excellent point. It's really a bottleneck in how we might move forward with some of these initiatives. I think the other thing that the IGNITE network nicely points out is the importance of how we deliver the information not only to patients, but how we deliver the information to providers, so that there are clear messages that are sent about how genomic findings can actually be used to take care of patients. And I think the results from the IGNITE study showed that they're able to deliver this genomic information to providers in a very quick, timeline, so that providers can, in real-time fashion, make decisions about medicines to be used for patients. And I think we probably have some work to do with our EHRs to provide that decision support to our providers so that they can, in a busy practice, use some of this information to actually guide how they take care of patients.
That was a great point, Svati. So, the summary statement, I think, as leaders in the Functional Genomics and Translational Biology Council, is to foster precision medicine I think going forward at AHA next year, we will continue that theme, and we will do so in collaboration with all the other councils. I think these concepts are pervasive, and they're not just genetic. There are many ways to find the right treatment for the right patient at the right time.
I want to thank you for all your efforts on the Precision Medicine Summit. I think it turned out wonderfully.
Thank you, Svati.
Thank you for having us.